Okay, officially, it is now time to start this party. So again, I want to welcome everybody and thank you all for joining us. This is the New Mexico Child Ready program, and this is the Child Ready Web Talk. And this evening, we have with us Sean Robertson. He is an EMT paramedic, and he's been doing this line of service for about 23 years, as I understand it, Sean.
That's correct.
And you are currently the QA coordinator over the Jemez Pueblo EMS.
Correct.
Tell us a little bit about your background. And
well, I knew that I wanted to be a paramedic when I saw reruns of Emergency as a child. And,
story I've heard before.
As a junior in high school, my dad took an EMT basic class, and I read the entire textbook in 2 days. And I proceeded to become an EMT basic at the age of 19. I went to paramedic school. I turned 21 in paramedic school. And came out here and started working right away in 1995. I was hired at Albuquerque Ambulance in 96. They promoted me to field supervisor in 98, and I stayed there full time until 2012. I still work there part-time as a paramedic educator.
Nice.
Teaching a lot of cardiac classes mainly, and my full-time gig at Jemez Pueblo since 2012.
And Jemez Pueblo, I love going out there and working with your injury prevention staff or do car seats, and it's a great place. And I feel very safe taking my children out there.
They're top notch.
He is going to be talking with us this evening on pediatric asthma. And that brings me to Dr. Robert Sapien, who happens to be another pediatric asthma champion in New Mexico and across the nation. It's, our leader here over at the University of New Mexico Pediatric ER. Thank you, Dr. Sapien, for taking time out of your extremely busy day to come in and be part of this as well.
Not at all. I want to add my thank yous to Sean for helping me. I've known him for many years, probably all 23 of those years.
Possibly is.
Worked on some level. I've been here 27, so yeah. Do you remember on Emergency Rampart and where the radio room was in emergency and that ER that they would drive up to?
Vividly.
That's where I did my residency.
Outstanding.
Yeah. That's where that was Harbor UCLA. That's what they used for the backdrop for that show. So, yeah, and I through our asthma work, we know that unfortunately, Jemez children are really overrepresented in asthma, and some estimates have that community asthma rates in the 20% or above, whereas the national average is about 12 to 14%. So I'm not sure if that holds. I'm looking forward to your talk to help elucidate that.
A little bit more about the other guests that are here in the office. Again, I mentioned them earlier. We have Joan Caldwell and Laura Grijalva, who have many years of experience in our pediatric ER. We want to thank them as well for coming in and helping us with Child Ready Web Talk. Very quick, this is the program overview. This is a approximately quarterly call-in show, I like to call it. We do have CEs available for this evening. If you are not prompted, if you have registered through the webinar and you're not prompted at the end to get your CE, the email in front of you, please write that down. If you're joining us on the webinar and you listen for the entire hour and I will take your word at it, we will offer you an hour of special consideration CEs from the New Mexico Department of Health EMS Bureau. We do have nursing CEs available. Just keep that address in mind. And
excuse me, they'll get an email in a day, 24 hours from this.
There you go, 24 hours from today. Again, there's my phone number there, 269-0347. It's a 505. Text with questions, pediatric asthma. I'm looking forward to this. And we do have an anticipated January, February 2018 date. I'm not quite sure on when our guest speaker will be available, so we are going to let you know more as we get that firmed up. And let me share this screen. I hate to go with the black screen there, but I'm going to pull up Mr. Robertson's asthma module, and I will turn it over to him.
Alrighty.
Thank you, sir.
Catherine. Well, this is a subject that's near and dear to my heart. I was born with asthma. I was hospitalized 5 times before I was 6 years old with pneumonia as a result of asthma exacerbations. I'm told by my parents I stopped breathing on them. one time while they were driving me to the hospital in Springerville from our home in Dattle. And yeah, so that might account for some of the brain cells that are missing now. I don't know. But anyways.
I actually know where Springerville is. We had a speaker that came in and talked to us about their bus crash in Springerville.
Oh,
So
it's beautiful there. Beautiful there. I love Springerville.
Well, I'm glad you're with us today.
I appreciate it. Anyhow, just some quick statistics. I pulled these off of the CDC website. And I've noticed I've been following these statistics, and they seem to have gone down in overall number for the most part with over recent years. But currently 6.2 million U.S. children under 18 have asthma. 2.9 million of those have had an attack in the previous year, and it's the leading cause of chronic disease in children. 44% of all asthma hospitalizations are for children, which is, I guess, not surprising. Lots of missed school days, and 40% of children who have asthmatic parents will develop asthma as well. I'm an anomaly. My parents don't have asthma, so I don't know who to blame. As far as defining it, we'll define it as a chronic respiratory disease. It's characterized by sudden recurring attacks of labored breathing, chest constriction, and coughing. It can fall into the COPD category as far as chronic respiratory diseases go. And this picture is pretty interesting. I found this picture on the internet, and the story behind it is a child was asked by a doctor to draw what it feels like to have an asthma attack. And this is how the child drew himself. And I don't know if he was prompted to put the blue on the face or if that's just something that he came by of his own accord, but it's pretty interesting to see. And for those that don't have asthma, if you want to experience an asthma attack, just take a nice regular breath in and then breathe out through a coffee stirrer, and repeat that over and over again until you can't do it anymore. And that's pretty much what an asthma attack feels like. So, covering a broad spectrum of asthmatics, basically it's an allergic reaction. It's the body's immune system responding to a trigger that causes asthma. Now, I understand there's other causes or triggers for asthma attacks that lie outside of the immune route, but this covers the large portion of asthmatics. A lot of asthmatics will have current allergies to other substances, foods, danders, pet danders, stuff like that. Oftentimes when they have an asthma attack, that they're triggered by a substance that they're allergic to. In my case, it's cat dander. You can get all the symptoms of an asthma attack, including some allergic reaction symptoms, some urticaria.
In my case, it's cats.
My fault, that's my technology not working.
Just trying to
No
follow
worries.
questions.
And it's uncomfortable for the most part. So when we think about it as basically an allergic reaction in our lungs, then we have to understand that we have to be sensitized to a substance, whether it's peanuts, whether it's dust mite, feces, whatever. We have to be sensitized to that in our immune system. And when we re-expose to that, then our immune system can respond by the process that we'll talk about here in a bit. And you can have an early and a late phase to this. So the early phase would be some initial bronchoconstriction and discomfort. But the late phase process, which involves edema, mucus production, is really kind of the big bad elephant in the room per se. So when we're exposed to these, whether it's via inhalation or ingestion, then our body recognizes the substance as foreign, and it decides to mount a defense against it. And basically, in our immune system, we have antigen-presenting cells. They recognize the foreign protein or antigen, and they swallow it up, basically. They just totally engulf it, and they take it to a T lymphocyte. The T lymphocyte basically says, okay, that's a bad guy, so we're going to start releasing cytokines these cytokines go to B lymphocytes, and the B lymphocytes then they become plasma cells, and they start producing an immunoglobulin, specifically IgE. And these antibodies are specific to whatever the antigen-presenting cell encountered. So if it's a cat dander, a protein in the cat dander per se, then whomever has an overexpression of cat dander sensitized IgE in their body can have an asthma attack to that cat dander. So IgE is basically produced by plasma cells, and it floats around in the plasma. And when it finds a mast cell, it binds to it. And imagine, if you would, a mast cell with all these little tiny keys bound to it. It's like an armed grenade. Maybe you pull the pin on the grenade, just waiting to encounter the protein that caused the production of the IgE to begin with. And once that protein cross-links with two IgEs, and enough proteins encounter and cross-link with two IgEs, then you have the mast cell activated and it begins to degranulate. Here's a picture of IgE. And Dr. Sapien, if you have anything to add.
I have my list of
Outstanding. And here's a little picture basically describing what we're talking about. With the antigen-presenting cell showing the antigen to the T cell, the cytokines activating the B cell to become a plasma cell, which is basically an IgE factory. And then they seek out mast cells and bind. And then once you have the second allergen exposure, then the mast cells are activated and they release all the contents of the little pockets inside them called granules. They move to the surface of the cell and spill out all this horrible, terrible mucus-producing inflammatory bronchoconstrictive substances. Among those are histamine, leukotrienes, prostaglandins, and such. So here's some pictures of mast cells, and in the lower left, you'll notice there's a mast cell degranulating. And it's basically moving all of these granules or pockets of I like to say pockets of goo to the cell wall and opening up, and it just exposes the body to these things. So bradykinins are carried by mast cells. And basically, what I get from this definition of bradykinin is that it's a potent agent of arteriolar dilation and an increased capillary permeability. That tells me that they're going to be a big player when it comes to edema and moving fluids from the inside of the blood vessels out into the other tissues, third space in the fluids. Prostaglandins are carried by mast cells. They are also powerful vasodilators. They inhibit platelet aggregation, and they're a mediator of inflammation. And then cytokines, basically they trigger inflammation and respond to infection. Now, it's kind of funny, when I was doing my research on asthma, I got into some pathophysiology to understand, and disease processes that were absolutely completely over my head, 100%. But I copied and pasted the definitions as they were written, because I think it's important to understand the nature of these substances as far as a paramedic is able to understand them, or whomever else is here. Okay, so the pathology of an asthmatic's airway. Sitting here right now, a lifetime asthmatic, I can say that my airway pathology is different than a healthy person who doesn't have asthma. They call it airway remodeling, and basically what that means is you get hypertrophy of cells, especially the smooth muscle that constricts the bronchioles. It turns into an Arnold Schwarzenegger-like strong little muscle. You get hyperplasia of cells. You have excess cells that produce mucus, excess cells that that basically fill the space that would normally be a nice open airway lumen. And so asthmatics exist with a smaller lumen when they're healthy and not being affected by the disease process than the person who doesn't have asthma. And here's an example of a normal bronchus on top and then an inflamed bronchus. And if you can see the size of the lumen, it's exponentially smaller. Just all that swelling and horrible stuff that's going on. So if you think about it, breathing, when we breathe in, when we inspire air, it's an active mechanism. We're using muscles to engage our diaphragm and our intercostals to create a vacuum, create a negative pressure, and draw air in. But when we breathe out, that's a passive action. It's absolutely dependent on no obstruction in order to get air completely out of our lungs. And if there is, in fact, obstruction, it's easier to get air in because it's an active mechanism than it is to get out. And that's the whole premise of asthma. You trap air with lower airway obstruction. That's what causes the wheezing. That's what causes the dyspnea and all the other symptoms associated. There's another image of a normal healthy bronchus on the left. On the right, you see hypertrophy of the muscle layer, an increased number of mucus glands, and it's not a good thing because it makes what normally would be a nice open airway super tiny, and you cannot get air back out. So responses to asthma. Oftentimes when we have an immediate response or to a trigger, it responds, we can expect a good response from rescue inhalers and such as albuterol, Xopenex, anything like that, any beta-2 agonist. The problem is, in some asthmatics, once they have that trigger started, then it's highly possible that the entire process can start that would cause the mast cells to degranulate. And then you can have symptoms that worsen later on and are no longer responsive. They're refractory to bronchodilators. So these are the patients that we really have to be careful of. These are the patients that we encounter at whatever time during the day, maybe even at school. They had an asthma attack and they took their inhaler and they're fine. Mom signs a refusal, and 6 or 7 or 8 hours later, we're back at their house because their inhaler's not working anymore, and now they're in a world of hurt. Now they're in it bad because not only do they have the bronchoconstriction, they have this process that's producing edema and mucus and just causing bad things to happen in the lower airways. So that being said, as EMS and medical providers, what can we do? What can we do to ensure that we're assessing and treating these kids appropriately and effectively? It's pretty important. I wrote this from an EMS perspective, so I put it before your shift. Understand that anything that we put on our bodies can be a trigger, whether it's perfume, cologne, aftershave. It doesn't matter what. If we douse ourselves with foo-foo juice, so if maybe, there's a lot of single EMS providers out there, and they're trying to look good for the other single folks out there. Just please don't douse yourself with colognes and perfumes and such, because it could potentially be detrimental to patients who are hypersensitive to these things. Another big one, I'm an animal lover. I love dogs. I can only have certain dogs. I can only have like poodles, water dogs, Bichon Frise, dogs that don't produce dander as much as others. So
they're dogs that have hair instead of fur.
They have hair like you and I have hair. So I can have these dogs, but any other dogs I can't be around. And I can tell if I'm working with a partner who has animals, if they've roughhoused and wrestled with their Labrador Retriever, and they show up to work with me and they have that dander all over their clothes, well, eventually I'm going to know, because I'm going to have to start getting my inhaler out and using it. So if you have animals, understand that that can be a trigger for patients. So, maybe don't roll around with the dogs or cats or whatever it is before your shift, or at least use a lint roller, to clean your clothes off, something like that. Also, cigarette smoke is a big trigger for asthmatics, and we have a lot of folks in EMS and the medical field that still smoke. So if you do smoke, and I can't judge anyone for that, but if you do smoke, please, don't let the cigarette be upwind of you. Stand with the cigarette downwind and try not to let it saturate your clothes. Wash your hands when you're done. Just basic common sense stuff, Also, before the call, have equipment that works. Make sure your stethoscope works. Make sure that the diaphragm's not busted. Make sure your pulse ox and your monitor with if you have a heart monitor that has capnography, make sure all that's intact. You have adequate supplies, adequate probes and such, so that you can put patients on that. Make sure you have enough oxygen in your truck to run a serious respiratory call. That's something that's big, especially where out in Hamas. If we don't have enough O2 in the truck to manage a patient with status asthmaticus, then we're up a creek. On the way to the call, always approach the call with the presumption that the patient is truly sick. Now, I've been in EMS a long time, and I understand cynicism 100%. And it's hard to get over that, especially if you're going to a high school for a teenager who's having an asthma attack. You always, the first thing, at least that pops into my mind still, is, oh, it's drama. And I've actually been caught off guard a few times by approaching a call thinking it's, status dramaticus, and it's actually, someone that's really sick. So please try to keep the frame of mind on the way to the call. And this is mainly me preaching to myself that someone is truly sick, and mentally prepare ourselves, because sick kids, that are asthmatics, they can absolutely deteriorate on you very, very quickly. And you need to keep yourself in the mindset for that. And I just want to stress it's important to presume that not all respiratory calls are true emergencies. So, kids have smaller airway anatomies than adults do. And if you're using a regular sized stethoscope on an 18-month-old, then you're probably going to hear a whole lot of stuff going on every time you put that stethoscope to the patient's chest wall. Try to keep a pediatric stethoscope. Most services provide stuff like that to their staff. But please, if they don't, lobby your supervisors to get pediatric sized equipment in your ambulance so that you can assess these kids appropriately. Kids will have a greater emotional reaction to uncomfortable and scary events. They just do. They're not little adults. They don't think rationally. Metaphors are horrible. When you say you're going to listen to their chest to see if you hear animals in their chest, they're going to think, well, do I really have animals in my chest? And it's simple stuff, Don't speak in metaphors. Be straightforward and honest with kids.
We just like to hear you talk.
Yeah, that's all good. Kids also can have poor compliance with their medicine. It really lies, the onus lies on the adults in the family to make sure the children are taking their meds. And also doing other preventative things like monitoring peak flows. And we'll talk about that here in a little bit. And here's the big kicker. Kids want to be normal like other kids. Any kid that is not considered normal is often ostracized or bullied. So if you have to go to the nurse to take, to take your medication, or if you have to carry an inhaler around with you, you could be singled out as a child, and no one wants that. So they can oftentimes not take their medicine on purpose to try to appear normal. And I don't know, every time I do this talk, I think of the movie The Bad News Bears with Walter Matthau. And he's basically telling his kid to go out there and play baseball, and he doesn't want to hear nothing about no stinking asthma. Asthma has kind of been viewed in a poor light when I was young, and I was one of these kids that was picked on because I had to have an inhaler with me at all times, and I used it frequently. I was a sick asthmatic as a kid. So when we're taking a history, with most kids that we encounter, we're going to direct the history at the parents. The parents are going to be able to tell us a lot, especially if, they're not absent parents or neglectful parents. They'll be able to tell us how bad the attack is. And oftentimes they can rate it on a scale of 1 to 10, how bad it seems. It's super important to know this. Has the patient ever been intubated or had an ICU admission or placed even on CPAP? Those are fairly important pieces of information to jot down and to share with the receiving facility. If the patient tracks peak flows, ask them what their best is and what their current is. And peak flows are basically, if you are doing good, for a few days, and you blow into a spirometer, and they're just little plastic devices. They come in all shapes and sizes. When you track your best, then you get a number that you use as a benchmark. So, for example, my best peak flow is 800. So I know that if I'm within 80 to 100% of 800, then I am good. My asthma is well controlled. And I still track peak flows. I do. I don't do it as often as I should, but I do it. Once you drop below 80% and you get down into the yellow zone, which is a 50 to 80% of your best peak flow, that's an area that you can live in and not be symptomatic if you are not active. So if you're in the yellow zone, you may not know it unless you track your peak flows. And most patients that track their peak flows have a treatment plan established with their primary care physician or whomever is following them to start maybe a different medication when they hit the yellow zone. Maybe they start a steroid burst, or they add nebulized beta agonists and maybe even some anticholinergics to the mix in this. And if you're at less than 50%, then you're probably symptomatic, and you're probably going to be calling 911. And those are the folks that get pretty sick.
So Sean, about how many, when you're doing your pediatric calls, how many patients actually have this information or know this information when you get there?
It's funny. It's a 50% split for me. I've had parents that are absolutely on top of it, and they'll give me, they'll keep track of the peak flows, and other folks not so much.
What about if you're called to a school, would that nurse should have this information as well?
I wouldn't expect a nurse to have that
No.
information. That's a lot of responsibility for one person on the part of a nurse who has a school full of hundreds of kids. So yeah, I wouldn't expect that, but I would expect parents to do this. So you folks out there, if your kid has asthma, monitor their peak flows, please. Okay, so now getting down into treatment. When we treat kids, reassurance is important, and don't tower over them. Little kids, you walk in, and if you're an average sized guy, you're a giant to a 2-year-old. And I'm not an average sized guy, so I can't imagine how imposing I look to young folks. So get down on their level and take some of that anxiety out of the picture. Oxygen for folks that are hypoxic or if they're dyspneic and they're under 94% is kind of a good area to consider oxygen on these guys. Here's another important fact that I want to add. Asthmatics whom you're responding to are almost always going to be dehydrated. Because if you can't breathe, you don't want to drink. And not only that, you're probably breathing at an increased rate and you're leaving all that water vapor out in the atmosphere. So consider an IV on the folks that need them. Albuterol, absolutely. Our dosage in kids is protocol driven. Generally, the accepted dose is 2.5 to 5 milligrams, depending on the age. You can also, and I didn't write it on here, you can also consider an anticholinergic, Atrovent, with the older kids. And that's generally 0.5 milligrams. You nebulize that as well. If you have kids that are super sick and you need to consider epinephrine, you can consider epinephrine, giving it IM. And I believe the dose is 0.01 milligrams per kilogram to a max of 0.3. Corticosteroids, absolutely. Those guys are going to be our friends. Those are what keep the entire immune response at bay. And again, this is also protocol driven. A lot of folks carry dexamethasone, and a lot of services carry Solumedrol. The benefit of dexamethasone is if you have access to some apple juice, you can actually put the dose in the apple juice and have the kid drink it. You can give the IV solution PO. So that's a good benefit to that. Now, if you are having to consider bagging a kid, then you need to be really, really on the ball. Because if they're exhausted and to the point that they're no longer able to keep up the mechanism of ventilation, then they're fixing to fall off the edge of the cliff, per se. And that cliff will come really quickly, and they will decompensate and they'll code on you. So please be on top of it. Give them positive pressure ventilations. If you do give positive pressure ventilation with a bag valve mask, please, please, please only give enough volume to create gentle chest rise and allow extra time for that air to move past those constricted bronchi. Intubation, as far as pediatrics go, is out in the state. But that doesn't mean you won't have a 14 or a 15-year-old that qualifies as an adult by protocol and will be intubated. Now, the consideration with intubation, and at least one big consideration in my mind, is you're taking away a protective measure that these kids use to kind of stent their small airways open, which is PEEP. Oftentimes when you see these kids and they're in extremis and they're tripoding, they're pursed-lip breathing, or they're making some sort of a positive pressure breathing out against some sort of a, maybe they're grunting or they're humming. It was me. It was humming for me as a kid. I'd hum. But that's them being protective and trying to stent those small airways open. So, do you guys mind doing a case study with me?
Yeah.
All right. Okay, so we're called to a local residence in an average neighborhood, well-kept home. We'll say that, for a 14-year-old female having an asthma attack. It's 5 o'clock, weekend day. What are we thinking on the way to the call, guys? Sorry, you're in the ambulance seats with me. I apologize for putting you there. But
We're going to take the call seriously.
Thank you. All right.
I like it.
That it's not a drama.
It's not a drama queen, right?
Mm-hmm.
And we've already taken the consideration of making sure we're not carrying our pet dander on our clothes, and we haven't smoked a cigarette, and we haven't, doused ourselves with foo-foo juice to attract the other single folks.
I want to make sure we have enough oxygen.
Thank you. And we've already checked our equipment, right?
Yep.
Mhm.
Check
Good.
equipment.
And on the way to the call, we're anticipating it to be a legitimate medical call. Okay, so we arrive, we find a young lady sitting upright in a chair with her hands on her knees. Are we concerned about that presentation?
Yes.
Just that presentation alone?
Yeah.
Okay.
It's called tripod.
Tripod positioning, that's right. She tracks us as we approach. That's a good thing, right?
Good.
Mm-hmm.
We can hear audible wheezes across the room.
Mm-hmm.
Okay. So mom tells us the patient's allergic to horses and started wheezing after walking past a corral with livestock.
That's an issue. Trigger.
She's used her inhaler 3 times since the attack started 45 minutes ago with little relief. Now, what do we want to know regarding the inhaler that she has? What are some things that are important for us to establish right away? What does she take? Good. What else?
Does she use a spacer?
Oh, that's a good question. Yeah, most kids should use. Actually, everyone that uses an MDI should use a spacer. But I want to know: is it expired? I'd also like to know: is it empty? And most inhalers that you get nowadays have a counter. They come with some sort of a counter, so you can track the amount of doses left in them. But if you're old school and your inhaler doesn't have a counter, you can actually test to see if they have medicine in them or not by dropping them in a glass of water. And if they float, then they're empty. If they don't float, if they stay suspended underwater or sink, then you still have medicine in them. Okay. So she has a patent airway because she's speaking 5-word sentences to us. She has labored breathing with audible expiratory wheezes. She has strong distal pulses on our initial assessment. A secondary survey, her skin's pale, warm, and dry. There's no obvious visible signs of external trauma. Lung sounds reveal expiratory wheezes in all areas that are listened to. And she's also complaining of itchy eyes. Darn that horse stander. Blood pressure is 132/76. Is that normal for a 14-year-old girl?
It's a little high.
That's a little high, yeah. Heart rate of 116. Strong and regular at the radial side. Is that normal for a 16-year-old?
It's a little high.
Okay. Respiratory rate is 24 and appears labored. That's obviously not normal. She sat in 93% on room air. Glucose was 78 because we are thorough and we check everything. Except one thing I didn't check. Did you guys check a vital sign that I missed? Temp? Yeah. Okay. Well, we don't really check temps as often as in the field as they do in the ER. But folks with asthma, we like to put them on capnography. Yeah. So what I was going to add to this scenario and forgot was that her capnograph was at 34 with an obvious sharp fin pattern.
What was your SAT again? I'm sorry.
93. 93 is, and that could be relatively low for a 14-year-old. You know, it really could be. So would we give her 5 milligrams albuterol right away? I would.
Yeah.
I just give her 5. What else will we consider on this kid?
She needs oxygen. I don't care what her SAT is. She's tripoding, she's wheezing.
Thank you, Dr.
She needs
Sagan.
oxygen.
I agree. She absolutely needs oxygen. We can consider ativentin her, absolutely. And what we're going to do in EMS is we're going to give her a nebulizer driven by oxygen. So that's absolutely going to be something that's beneficial for her. After the 5 milligrams of albuterol, she reports feeling much better. Lung sounds reveal only slight scattered apical wheezes. Here's the big question. Here's a big question. Do we transport this kid? And I'm going to get a 50-50 split for the most part on any EMS provider that I ask. Some are going to say, yes, absolutely. Some are going to say, well, let's ask mom what she wants to do. And always we're going to say, mom, we'd like to transport, or mom, what would you like to do?
Are they living in Daddle?
No, they live here in town. Yeah, they live up in the valley where it's kind of a mixed agricultural, lots of homes with big properties and horses and such. In this specific case, mom said, no, we have a plan. I can get her into her primary care physician within 48 hours. We have the nebulizer here at home, and we can continue to treat her as needed. So mom signed a refusal. And as long as her vital signs are normal and she's no longer symptomatic, I'm okay with that. Now, we're continuing our shift, folks, okay? So here in town, we use medical priority dispatch. So we're called to a 6 Charlie 2, a 7-year-old male with asthma. And as we arrive, we find a frantic mom holding her child in her arms. She tells us that her son has had a cold for 5 days, but today he's become listless and doesn't seem to be breathing right. So we have I said 7, yes, good. A 7-year-old who's gaunt. He seems to be staring off into space. He's got dry mucous membranes and some cyanosis around his mouth. Here, his lungs are diminished. We hear no wheezing. We see intercostal retractions, tracheal tugging, nasal flaring, and central cap refill is 5 seconds. Mm-hmm. So where are we with this kid? Sick. This kid is super sick, and he's super sick, we know, because he has an altered mental status, right? Yes. If you have a kid with altered mental status who presents with these symptoms, then you have a super sick kid. And here we see some intercostal retractions. I had a video. I couldn't get the video to attach to the presentation, so I just put in a snapshot of it. But it's fairly dramatic intercostal retractions. So is this a stay and play or scoop and run? This is a scoop and run. It really is. Everything that needs to be done by EMS will get done on the way to the hospital, or it will get done in the hospital. Do we want to know anything else about this kid in his current presentation? Okay. Yeah, so what we hear is that he was premature. He had RSV as an infant, and he lives with a diagnosis of asthma that he received about a year prior. Mom has an albuterol MDI with a spacer, and she has also a Flovent MDI with a spacer that she gives him as needed, and he also takes Singular. I didn't put that on here, but that's what he takes. And as we know, Singular is a leukotriene inhibitor, so it basically kind of stops the leukotrienes from causing all the mayhem that they cause. And those are the baddies that are carried in mast cells. So we have a brachial pulse at 170. BP is still 90/40. And here's the question I have for you guys in here. When you have a kid this sick and with that pulse that you're finding only at the brachial site, how accurate do we expect the blood pressure to be? I don't put a lot of emphasis on blood pressure in this case. I just don't. I may be wrong for that, and Dr. Sapien may correct me partially, but I really don't in the grand scheme of things.
No, I agree. I think you have enough. You almost don't need a blood pressure. You have enough with a pulse of 170 and a cap refill of 5 seconds.
Okay, good deal. So he's breathing 42 times a minute, satting 80% on room air. End-tidal CO2 is at 55 millimeters of mercury. And this is what we see on the waveform. So that's a clear shark fin pattern. That's evidence of clear lower airway obstruction. So what are we going to do for this kid?
I would like to start with IV and oxygen.
Yeah, and hopefully simultaneously a lot of things are going on, right? Because we have lots of hands. All you guys are very capable. So we're going to start with ABCs. We're going to ensure that he can control his own airway, and then we're going to start ventilating, right, with 100% oxygen. And while that's going on, we're going to try to gain vascular access. And yes, O2 and BVM, you betcha. When is intubation considered? Intubation is going to be considered, in this case, in the emergency room. And this is a yes and yes question too. And this kid needs fluids. He really does. And if you do it through an IV or an interosseous route, just get it done. And it's kind of interesting to see the evolution of interosseous access over the course of my career. When I first came up in EMS as a paramedic, it was pretty much the jam sheety that we used. And we really were kind of scared to use them, and the PALS introduced the guideline that it should be 90 seconds or 3 IV sticks before you consider an IO. And nowadays, if you look at the kid and he looks sick and you think it's going to be an IO, start an IO. We have tools today that make starting IOs a lot easier, including the Easy IO drill. So there's no reason why you shouldn't consider the fastest access possible that's going to be successful. And yes, fluids. How much fluid? What's the rule of thumb? 20 mils per kilogram. Repeated as necessary, right? How about epi? We're down into we're treating some life threats now. And one of the life threats is lower airway obstruction because lung sounds were diminished and we didn't hear hardly anything. So what do you guys think about epi?
It's been a while.
Yeah, I say yeah. I say I'm giving him epi, and yep, bag some albuterol. You betcha. So we put the O2 via cannula because we already have him on the capnography, and we start a neb. We start banging it in. We start an IO and start fluid bolusing. And during transport, he became apneic and required a bag valve mask.
Why didn't you put him on an honorary breather?
Or bag admission.
That's a good question. We could have put him on an honorary breather, but then we wouldn't have been able to get the nebulized epi in, or excuse me, the nebulized albuterol in there. So giving him the oxygen via cannula and via O2 driven nebulizer was the reasoning for that. Yeah. And soon after all this started, patient lost pulses and we started CPR. So at that point we divert to the closest ED because that's the cardiac arrest protocol. He arrived pulseless with asystole on the ECG. The ED continued resuscitation efforts for 30 minutes and then discontinued. So this was a truly sick kid. And there's not a lot you can do once you're past the point of no return on these kiddos. So I think the emphasis needs to be on keeping kids from making it to that point to begin with.
Yes, if you look at the survival statistics of a child that goes into respiratory arrest but maintains cardiac output, their survival rate is upwards of 80 to 90%. Look at the survival rate of a child who undergoes cardiopulmonary arrest, their survival rate is less than 7%, and that's in the ideal situation of being in an intensive care unit with all the appropriate equipment and everybody anticipating that event. So.
Right, that's when the arrest occurs. And that's scary. And this kid was in severe cardiopulmonary compromise. He was, just so dehydrated, sick. Could we have obtained any other history through that? It's a good question to ask after the fact, but when you're dealing with a sick kid, it's kind of hard to try to obtain history when you're treating life threats. And that's the first step in dealing with these kids. And then once you deal with life threats, then you enter into the secondary assessment where you start obtaining all the history, the sample history, and all that. And if you're absolutely dealing with life threats, it's hard to get histories. And I know that's hard on the receiving facilities, especially if they haven't seen the kid before. But that's just a barrier that exists in EMS. Would we have treated anything differently? I don't think we could. We treated life threats. And if you're treating life threats, you're doing the maximum possible. Why did the patient code? This is almost a rhetorical question.
Mm-hmm.
He was too sick to be resuscitated when probably 911 was called.
He has a history. He had a history of being a preemie and RSV and other.
Yeah.
And then it seemed like the call came in pretty late into his condition.
Yeah.
He was so dehydrated.
Okay. How are we doing on time? Do we need to?
We've got about 8 minutes left. I'd like to leave a little Q&A
Okay.
time at the end.
Well, let's stop here then.
Okay. Well, I'm going to have my own different set of questions. I'm going to let Dr. Sapien. What do you have for Sean? I saw you taking some notes.
Yeah, I have some notes, but I want to start by saying that's the best asthma lecture, EMS asthma lecture I've ever seen.
Well, thank you very much.
I agree. I am
Was so complete.
And so personal and so it really the perspective is spot on.
Yeah.
So thank you. I enjoyed that. I've learned a lot.
So just some other, and I don't know if they're questions as much as just additional information. So some other triggers that are non-allergic, certainly cold air, exercise, you mentioned cologne, tobacco, all of that stuff. Stress in itself and emotions can be a trigger to asthma. So those would be things to consider. The other thing was when you talked about the airways being smaller in children, the entire body works by physics, and so there is actually an equation which looks at the resistance of airflow going through either with fluids or with air, and part of the equation is dependent on the resistance increases as the radius decreases to the fourth. So you already have a child with small airways, and now you decrease the radius of those airways, but it's even more pronounced than that if you look at the resistance that it produces. It's to the fourth, so not squared, but to the fourth. And so that can really add to things. And you did a really good job about the early and late phases, but I think they're not quite so distinct, and that even with the first, like in the first case you talked about, she had an element of edema, even though we were treating bronchospasm. She already had an element of edema, which, although the mother refused to transport, I would support transport just unless they had.
Had we continued with the study, we would have returned to the house.
If they, to give some anti-inflammatories. And stuff like that. You mentioned that part of the history is whether the child or the patient, in general, even the adults, have been intubated or in an ICU. Where that comes from is from older literature, asthma literature, showing that if a person has a history of being intubated or has a history of being in an intensive care unit, it's associated with sudden death from asthma, and so it puts them in a higher risk category from the get-go for sudden death. It also is an indicator of how well controlled their asthma is. We talked about asthma and oxygen, and I'm a firm believer it doesn't matter what the O2 saturation is. If the child is in distress, then definitely I would go ahead and start asthma. Oxygen rather. Also, PEEP, and you did a really good job explaining that. Anybody in the room know why PEEP is so important and what the benefit of it is in asthma? So remember it's positive end expiratory pressure. So it keeps the alveoli open, but why is that important?
Well, it maximizes the surface area which gases can exchange.
Right, but it all comes down to physics again with the body. So if we look at energy expenditure, opening an airway, an alveoli that's collapsed takes more energy than keeping an airway, an alveoli open with PEEP. And so again, it comes down to physics. And then the participants in the room talked about giving fluids at 20 cc's per kilo, but how do we know what this kid weighs? And so some of the possibilities, of course, are brasso tape carried in the back of your rig, or that really quick formula 1, 5, 10, 10, 20, 30 that I wanted to remind folks about. So 1-year-old weighs approximately, so 1, 5, 10, 10, 20, 30. A 1-year-old weighs approximately 10 kilograms, a 5-year-old approximately 20 kilograms, and a 10-year-old approximately 30 kilograms. That particular case had a 7-year-old, so I would estimate him at a weight of about 25 kilograms based on that. And it's a pretty reliable weight estimate. So not so much questions as much as just kind of some additional information, but again, that was the best asthma lecture.
Thank you.
Thank you very much. Yeah.
And Sean, I just want to thank you again. I just have a couple of comments, I guess. Going back, we were talking about if you responded to the school, and I'm thinking there are definitely medical plans that you can work with your providers to make sure that the school does have that on hand, and it's a nice tool for them to use.
Right.
With
They have an
EMS when they can.
emergency form that they do, and if
Yeah,
and if it's the school system. It starts with a 5. The 5 is something plan or form. But it's it's for kids with chronic illness, and they will do a treatment plan. Many asthmatics don't, unless they're severe, may not have that plan. All kids with seizures will have a plan like that, et cetera, et cetera. But kids with asthmatics, just like you said, there's such a there's a wide range of severity, and they may not have that. But yes, they may have it on their emergency card.
if my grandson has anything like that, he will have a plan in place. And then how many pediatric calls, usually, what's the percentage of pediatric calls?
Now they're a lot lower because I deal with a lower response population. But it seemed that for the first 18 years of my career as a paramedic, I got at least one horrible, terrible pediatric call. And of those 18 that I got, probably 50% were respiratory.
So I'm just wondering, we have part of this group is the EMS for Children group, and one of the things that we'll be looking at in these next upcoming years, the next 4 years, is skills. Pediatric skills. So like being able to appropriately utilize that BVM on that child, or all these different types of skills associated with the asthmatic and respiratory calls. Is there something in place that in your service where you assess their skills with pediatric patients?
Well, generally we teach a cardiac class like PALS, and we use that as an occasion to really review the mechanical motor memory stuff, the muscle memory that you do when you treat the kids. We have some really good ALS mannequins that respond well to bag valve mask, and you can see good chest rise. So that's the best that we can do, other than just preaching good mechanics.
Well, I'm going to get you back out there, maybe do some more PEP classes and do some other things to share your wealth across the state, wealth of knowledge across the state. And I'm going to preach it, just practice your pediatric skills, know your protocols with your services, and
know your equipment.
Know your equipment for reals. Mm-hmm. So again, thank you all for sharing your time this evening. It is exactly 8 o'clock. Sean, thank you again.
It's my pleasure.
Great lecture. I enjoyed it very much. Dr. Sapien, Joan, Laura, thank you guys. And thank you all for tuning in to another Pediatric Child Ready Web Talk.
Yeah.